Can I just, as we have some time, would anybody like to comment on prophylaxis, laser prophylaxis for retinal detachment? I think we're doing less and less of that. And what are your guidelines on treating a patient at the moment? Can I repeat the question because it was apparently not heard? I said that we are actually doing less and less argon laser prophylaxis for retinal detachment at the moment. So I would like Linton to comment on what are his guidelines on treating patients, if any, at the moment in his clinic.
I would agree we're doing less and less and being sent less and less for prophylaxis. We currently don't treat outright asymptomatic round holes and asymptomatic operculated holes. So this is pretty broad. We don't treat lattice in the absence of symptoms and tear. So lattice as a prophylaxis, even in the fellow eye of retinal detachment. So fellow eye. And the ambiguous ones are symptomatic operculated tear, although fewer and fewer people treat these. Symptomatic round hole in lattice, and that's usually, it's only because there's a combination of symptoms, lattice, and a hole, and incidental findings of retinal tears without pigmentation. So these are still, there are still some ambiguous ones, especially where there are symptoms and a tear, or symptoms and a dual pathology, hole and lattice. And these are variable. I treat less and less of these. In fact, most of them I don't treat now. And the what's the rationale of it? I suspect for me the rationale is that one is we are being sent enormous amounts of pathology. In the past, it was rare to see lattice symptomatic, and therefore it was a relatively rare thing, and we saw detachments with lattice. Since the advent, certainly in the UK, of opticians who are looking inside the eye, we're sent enormous numbers of incidental findings of these pathologies. And it's the combination of the number of people we would need to treat and the fact that we're not seeing detachments from those types of lesions, despite seeing thousands of detachments, that makes me feel, using those two indicators, that the benefit to the group of prophylactic laser is low. And at the back of my mind, we used to be able to say it was safe, but we see tears along laser. So you can't even tell the patient that there's nothing to lose, because in the wrong patient, certainly with a stickler patient, someone who's a high myope, they may in fact tear along the laser, especially where you've induced a localized PVD, so it tears along the laser that you induced the PVD on. So on the whole, fewer and fewer.
Do you treat symptomatic lattice without break?
No.
What about in private practice?
It's not supposed to be different.
No, no difference between the two. In fact, I probably do less laser in the private practice.
That's integrity, you see? One question for Alex. Alex, it's very common in Greece, people who present with posterior vitreous detachment to be asked to refrain from all physical activity. And I know it sounds a bit odd, but it is, you know, it's rooted very, very well in the mind of the average ophthalmologist. Is there any evidence?
I'm not aware of any evidence myself, but it tends to, surgeons who tend to give these instructions tend to be more French-trained than Anglo-Saxon. This is what I've noticed, actually. They're very keen on these instructions in France.
Can I make a comment that on this? For all recommendations of rest, the most violent movement of an eye is an acceleration, deceleration, a saccadic movement, because it goes from 0 to 200 meters per second instantaneously. And the most violent series of saccades is while dreaming, while you're asleep. And so unless you can somehow disrupt people from sleeping or dreaming for 2 weeks after the operation, then stopping them from jogging or lifting or walking or doing anything is sort of irrelevant in terms of violent activity of the eye. And that's why I don't feel there's any good justification, because the most violent movement of the eye that's going to disrupt something happens anyway.
There is evidence from recent work from Demers in Amsterdam that if you have a detachment, not a posterior vitreous, a retinal detachment, bed rest reduces the risk of progression until you have surgery.
That's within 24 hours, not for 2 weeks after.
Not for 2 weeks,
Yeah.
yes, until you get surgery.
It's
Yes.
like you're patching as well.
Yes.
And they don't dream, they're so scared.
You suppress their
That's
dream.
right, you suppress their dreaming for one night.
Okay. We'll just carry on now with the MCQ. The question is, exudative retinal detachments, A, are always associated with inflammation, B, often have tobacco dust in the vitreous, C, are sometimes caused by central serous retinopathy, D, typically have exudates at the macula, and E, only occur in adults. So go ahead and vote. Have you all done that? Or?
Where do we find the results?
I will be shown the results. Okay. Can we see the results? Right. You want to elaborate?
Yeah.
Alex says this is your...
Well, exudative detachments are always associated with inflammation. That's not true because you can sometimes get abnormal scleral conductivity in uveal effusion syndrome causing the exudative detachments. Metastatic disease inside the eye can cause exudative detachments. So there are many other causes that, apart from inflammation that can cause this condition. Often have tobacco dust in the vitreous. That's not true because tobacco dust is pathognomonic of a break causing the retinal detachment. C are sometimes associated, are sometimes caused by central serous retinopathy. That's true. CSR can present as an exudative detachment. Typically have exudates at the macula. That's not true because sometimes you can get an exudative detachment without any exudates at all on the macula. And E only occurs in adults. That's not true either. It can happen in children as well.
So you managed to trick quite a few here. Well done. Carry on with the next question. Can we have Mr. Assis' next question, please? You had more than one question, did you?
Five.
You had five. Okay.
As requested.
Okay. Right, so here we are. Retinal detachment in children. A, are always exudative in nature. B, can be due to self-harm. C, only happens secondary to associated vasculopathies. D, are usually diagnosed early. And E, are easily managed. And, you like the number E?
Yeah.
We all love them. Everybody voted. Let's go and see the results. Right, okay.
Right.
Alex.
Detachments in children are always exudative in nature. That's not true because you can you can often get tractional or rhegmatogenous detachments in children caused by retinal breaks. Can be due to self-harm. That's true. Only happens secondary to associated vasculopathies. That's not true because, as I said, you can get them secondary to retinal breaks or traction on the retina. Are usually diagnosed early. That's not true because children fail to report symptoms, and that's why you need to examine them on a regular basis. Are easily managed. Well, not in my hands. I just find it difficult to treat detachments in children. So the right answer is B.
We'll carry on with your third question, but would you like to prepare to show a video as well? Because I know you have a couple of video cases, and we have... no, actually, we don't have much time. Sorry. Well,
So let's stick to the
let's take one more MCQ, and then we can end the session. And we have learned to be patient by now. So, okay. So anomalous posterior vitreous detachment, A, typically occurs in young patients. B, has symptoms different to that of a normal PVD. Can induce directly the formation of a choroidal neovascular membrane. D, can occur in the setting of a certain collagen diseases. And D, is due to complete vitreous separation before liquefaction of its gel structure. Can go ahead and vote. Okay, and let's have a look at the results. Right, okay.
Oh, good. Right. Anomalous PVD typically occurs in young patients. That's not true. It more often occurs in older patients. Has symptoms different to that of a normal PVD, where there's no reason for that. It causes the same symptoms of flashing lights and floaters. Can induce directly the formation of a choroidal neovascular membrane. Well, there's no evidence for that, so it was a tricky question. It can cause the formation of a neovascular membrane indirectly sometimes, but not as a direct consequence of that. It can occur in the setting of certain collagen diseases. Yes, that's the true answer, like Marfan syndrome or Stickler syndrome. And lastly, is due to complete vitreous separation before liquefaction of the gel structure. Well, it's the other way around. It's due to the liquefaction of the gel structure in relation to the vitreous separation from the retina. Excessive vitreous liquefaction. So the right answer is D.
Okay. Great, so we can carry on now with a lecture we have all been looking forward to, and that's again by Professor Da Cruz, whom we have exhausted today.
There are some questions.
Sorry, I have...
There are all questions here. Is there all question? Yeah. All right, there's one question here too. Yeah, one, two. Yeah, you're right. They are new. Yeah, okay. So one is for you.
Sorry.
Alex, is it possible to have ERM and full thickness hole at the same time? And are all holes related to ERM pseudo holes?
Well, it is certainly possible to have an ERM associated with a full thickness macular holes. ERM can induce the formation of a full thickness macular holes. So that's the answer to that part of the question. And the other part is?
The other part is, are all holes related to ERM pseudo holes?
Oh, can I just clarify that it's not the typical ERM that would cause a macular hole. It tends to be a star fold next to the macula pulling on the macula, causing a macular hole, a PVR star fold. And the second part of the question?
One more question. What is the risk of patchy vision after uncomplicated ERM peel?
Patchy vision. I'm not quite sure what patchy vision. No, I never get that.
Patchy, well, you get loss of vision, but not consistent. Not a.
Yeah, I'm not sure about the answer to that question. Any idea?
Well, I don't think it's a common complication of retinal of ERM surgery. It's very uncommon. You do get some patients that lose vision in an unexplained way after you peel the ERM, especially when you peel the ILM and you cause some dissociation of the optic nerve fiber layers. But that's not really associated with a complaint of patchy vision. If anybody wants to contribute to that question, anything further?
The patchy vision could probably be related to underlying photoreceptor damage from the chronicity of the membrane before surgery.